My name is Mary Sue Gardner, and I am going to be your educator for today's event. So a few things to go over. Every event, we have to show you our disclaimer and review our disclaimer. So if you listen this morning, still the same information. This education was prepared as a tool to assist you in the Medicare rules and regulations, but they often change. So just keep in mind, if the rules change tomorrow, it's your responsibility to follow those rule changes that are in effect on your date of service. We're going to provide responses to questions based on the laws, rules, and regulations as they are today. But Medicare has final determination and coverage. CMS also prohibits recording of this presentation for profit-making purposes. As I mentioned earlier, we are recording this for you, and pending the outcome, that will be on our YouTube channel as an encore of today's event. These are some acronyms that I may say or may refer to, or you may see in the documentation examples that are up on the screen. So if I happen to use an acronym, just refer back, to the acronyms list. It is in the presentation from this morning's deep dive into Medicare coverage for outpatient rehabilitative therapy services. So my objective this afternoon is for us to review some live documentation examples in an attempt to avoid unnecessary claim denials. And we're going to accomplish that by looking at some actual PTOT and SLP examples. So we're just going to jump right into things, and I am working on two different screens here, so you got to give me a second to pull things into view for you guys. But our first claim we're going to talk about is an outpatient therapy claim for physical therapy services. So this was a Part B outpatient therapy claim. This claim was for a 93-year-old female that lives in the Medicare unit of a facility, and she's got a noted decline in function. Her start of care was March 13th of 23. There was some generalized muscle weakness, difficulty walking, COVID-19, unspecified dementia. So those are some of the diagnoses that were listed. They also listed this as an insidious onset on 3/1 of 23, so just 12 days before the start of care. And they're hoping to improve patients' ability to perform safe walking, gait training. So I don't know where it went. Hang on. My computer is not playing nice with me today, so give me just a second. Okay. And I am going to maximize this. Oh, if my computer will play nice, so sorry. Let's just do this. Okay. Rachel, can you verify that you are seeing documentation on the screen right now?
Yes, we are.
Perfect. Okay. So I've highlighted a few things in here. Now, I want to remind you guys that for outpatient therapy, Medicare does not require you to have an order. This documentation starts with a physician's order, which is fine. If you get an order, that's great. Just keep it, scan it in. This patient happens to reside in a facility, so it's probably just part of their norm to, get the order and keep it in their documentation. But the services provided were outpatient, even though she lives within a facility. So as we scroll down, this is just some of the billing information, and I left that in here to show you how we look at a claim. So we're looking at these dates of service in August. We're looking at what was billed for those dates of service. They have some 97530 and 97112 on this date of service. We look at how many units. We go back to your documentation to make sure the documentation minutes support the actual units that were provided. So in this case, again, there's some things that I want to point out, and I'm not going to, as we go through these components of documentation, I'm really not going to tell you like, oh, we paid this one, we denied this one. That's not the point of this exercise. The point is to look at various components of documentation and look at what kind of documentation is really good and helps support the services you provide, and maybe what kind of documentation is kind of poor or lacking in different areas. So initial evaluation and plan of care, again, outpatient physical therapy services. We have a diagnosis of muscle weakness, difficulty walking, COVID-19. I don't know the status of the COVID, if it were when the dates of service were in effect or if that was an old diagnosis. They've got some hypertension, et cetera. Now, as we go through and we look at some of the information, and if you joined earlier, I told you it is permissible to evaluate and treat on the same day. So up here, they listed the therapeutic activities that were provided, the amount of minutes, et cetera. They did a PT evaluation. They rated it of moderate complexity, but 20 minutes. I'm not thinking that moderate complexity in 20 minutes meet that requirement. And I would have to go back and actually look at what the requirement is, you know, for estimated time for the 97162. But if you're saying it was moderate complexity, 20 minutes seems like kind of a little amount of time. Now, if you take into fact the 20 minutes of actually writing out the evaluation compounded with the 40 minutes of actually doing activities to assess that patient, then yes, then maybe it would be of moderate complexity. But just some things to keep in mind. So, you know, with the new evaluation codes, I shouldn't say new, but newer within, you know, the last handful of years when they broke up the therapy evaluation codes, there are some components of time that go along with those. So you have to make sure, you know, you're meeting all those requirements. All right, so the referral on this one, the stated referral was to improve the patient's ability to perform self-gait in the patient's environment on even and uneven surfaces independently. So we go through and we start looking at all of this information, because what we're doing right now in the review is we're trying to gather all the information about this patient and paint that picture. Like why, what prompted them to now need therapy at this time? Was there a reason for the muscle weakness, or is this kind of a gradual onset of patient decline that's been living in this facility for a while? So that's types of information that you want to let us know. You want anyone that picks up your chart to be able to know. If this is someone that lives in a facility, you know, and they said originally in the claim that this just came on several days before and it was an insidious onset, you know, like, do we have a reason for this sudden decline? So those are the things we as your reviewer look for. We look at, you know, are they currently using any assisted devices? What is the symptomology? Listed as pain, weakness, poor balance, poor endurance, you know, so what caused this? Patient is moderately independent independent in the Medicare unit with her forward or four-wheeled walker and verbal cueing to her daily tasks. So right now we're history gathering. Patients unable to ambulate distances due to weakness in bilateral lower extremities reported from the caregivers per her prior level of function. So the caregivers are saying that, she's experiencing these weaknesses, and that's why they referred her. So then we go through and look at the overall assessment of the patient and the things that, stand out and make your overall plan of care. What are you going to work on? So we know we have some gait abnormalities. She has some kyphosis, so she is bent over. She has some balance issues, et cetera. They assess some strength, so she's lacking in some strength. Her tug test is 21 seconds, so that's a little slow. She does ambulate 200 feet, so, she's got a slow cadence. She's using the assistive device, et cetera. And so we go through and we look at all of these pieces of information that you provided us. And here's where they kind of give an overall 93-year-old female in the Medicare unit, noted decline from her caregivers. They are reporting increased concerns about that decline. Patient having difficulty with ambulation safety and tolerance in the past few weeks. Patient's family reports increased fatigue, slow gait, greatly benefit from PT to maximize the environment and achieve the goals. So, which we see a lot of, especially, in the older population and patients that are living in facilities, and sometimes there is a decrease in decrease in overall function just based on living in the facility, maybe not moving as much as they should, not participating. And then we always have issues that come up that could be medical issues that cause this as well. Did she have, did this COVID knock her down? Like, when was the COVID? It would be nice to know if that was a precipitating factor that related to her generalized weakness or not. So there's pieces of information that are kind of lacking that could be better documented. We have a plan, and if you participated earlier, remember I said you need in your plan to have amount, frequency, and duration. And we have that they're going to do one treatment session a day, 3 times a week for 90 days for this patient. And they give a little bit more explanation in here. And then here's the overall assessment with where she is, where she currently is. This is the initial evaluation, so it's the same as her current, and where they're trying to get her to be. So remember, she does live in a facility, so that, happens to be probably why some of these things are not as independent as someone who maybe needs to go back home or, living independently, et cetera. So, in my opinion, the goals make sense for the patient. Now, her gait distance is, quite adequate right now at 200 feet. They want to get her to 500 feet. So, and a lot of that has to do with, like, maybe how far away is the dining room, and we want to make sure she ambulates within the facility safely. And so that may be a very, good goal for her, to ambulate that distance without any rest breaks, et cetera. And then certification of the plan of care. So remember, if you participated this morning, I said an order's not required, but the certification of the overall plan of care is required. So in this instance, and let me bring this up, Remember, we had a start of care of 3/13/23, and they actually got the physician to sign this certification on 3/16/23. So well within that first 30 days of service. So that all looks good. As we go through, and I don't have every single piece of information from this chart in here because that would just be too much and too overwhelming, because a lot of these charts are hundreds and hundreds of patient pages, especially when a patient lives in a facility. So here is just one of the daily notes that was provided. So you can see, as I said earlier, when you are charting your daily notes, we need to see what was being done and how many minutes that service was provided. So we have a CPT code for therapeutic activity, and we can see that they performed this service for 55 minutes. The nice part about this note is that they give us some additional information as to what they did during that 55 minutes. Remember, when we are reviewing your documentation, especially when it comes to outpatient therapy services, we're going to go out and make sure that the number of units that you reported for this specific day match the number of minutes that were actually performed, that it falls within that range. So as we scroll on down, the next thing I want to show you is a progress report. So this is just one of their progress reports. Remember, progress reports are due on or before every 10th treatment day. So for outpatient therapy services, and even if it were inpatient, you should do your progress report on or before every 10th treatment day. And that progress report has to be performed by the actual therapist. So on this day, they labeled this as progress reports. They said they did therapeutic activity for 45 minutes. They give us a little bit of information about the therapeutic activities that were performed. And then we start to see more information, objective information in here about where this patient currently is. So remember, when it comes down to a progress report, we want to see where was that patient at the start of care, where are they now? We need to make sure that the services that you are providing for the patient are making those, helping that patient make those functional gains or prevent that decline if that's what we're trying to do. And it can only be done by the therapist or the physician because it is a skilled intervention. It is a skilled service. It takes your knowledge, your expertise, your licensure to update a plan of care, to assess a patient's progress towards goals. So if anyone other than the therapist does this, we would not consider it a formal progress report. So when we review claims, and when most review entities that look at therapy services review claims, most of the eggs in the basket that we look at are the progress reports, because that's where we can see the big picture. The daily reports are nice. They give us that day-to-day what's going on with the patient, what kind of intervention, how long they spent. But the progress report is where we can see, hey, is the skilled therapist, in this case, the skilled physical therapist, doing something that is making this patient make functional gains? So you can see from the initial or start of care to the current, this patient has already made some functional gains at the time of reporting of this particular progress report. So we can see that, you know, from the initial evaluation, they're walking more, they have a little bit better strength, they're decreased heel strike, they're still at standby assist, but they're working, towards those functional goals. All right. So, and then it was signed by the physical therapist is what we would expect. And then we go on again, with some daily notes, and we check to make sure the daily notes, like this one, had a PTA, and the PT also signed off on it, which isn't necessary, but if that is what you guys do for your daily notes, then that's fine. You don't have to co-sign them because they're working under your supervision, but if you want to do that, that's fine. And then we go on, and there would have been more daily notes, but then we go on to the next progress note. And so some of the things that I want to show you at the point of this progress report, which was in June, you can see patient ambulated through the facility with a rollator, and they went 500 foot with supervision for safety, and that was their goal at the start of care. And so we go on and look at some of the improvements that were made, and I know I'm going through this quite quickly, but I want to get down to here. Oops. And so now they have updated the goal to 1,000 foot. So, the patient had met the previous goal, and instead of, okay, there we go. So goal met, and they upgraded it. So they did identify that over here. So that's a good way to let us know that, maybe that person exceeded the goal quicker than they thought, whatever the case may be. But as you move on, you start to wonder about, when do we stop? So the next thing I want to show you is that this was listed as their recertification. So it's just kind of a repeat of the daily stuff that was done or the progress report that was done. The PT has signed it, and I don't believe in this one that the therapist or the physician had signed it. Oops, nope, we have PT. And I think that one lacked a physician certification. So if that was listed somewhere else, that's fine. We'll accept the physician recertification. It doesn't have to be on any specific form, but that one just happened to be labeled as recertification, and there was no physician signature. Now, remember, I did say that the discharge note is part of your progress reports. So we do expect that a discharge note be written for each of your patients, even if they leave AMA or don't return or die or whatever the case may be. You should still close up your chart, end your chart with some sort of discharge note. Like, this patient left AMA, here's where they were on the last time I assessed them, and then they were seen by a PTA 3 times before they didn't return. So there just needs to be some information. So it is a component of your documentation to write a discharge note. Okay. So we're going to move on in the interest of time because I have several claims I want to show you. And our next claim is an OT claim for Part B services. And this is a 70-year-old male that lives in a facility as well. And he was referred for decline in function. He's been a resident of the facility since January of 2018. The start of care for this gentleman was September 10th of 2022, and it's listed as generalized muscle weakness. So as we go back, I'm going to go to sorry for scrolling so quickly. And this was part of a probe review is why this came in. So this was patient, or this facility was under review. And something I want to show you, and is not necessary. So this facility did provide an analysis of this patient, which is not necessary, but you can provide one. Our medical review staff will look at an analysis or a letter of, how do I want to say that? Like a letter about the review, but we're not going to look at that before we review the chart. We'll look at it after, but your chart needs to stand as is. So if we can't find the documentation in the chart, we can't pay you. If it's not documented, it's not done. That old mantra goes back to that. So a letter of appeal or a letter of, a summary of your patient's services regarding your care for them, it's not something we want to sway our decision, because that was written afterwards, and you can include whatever you want in that. We need to make sure your documentation stands as is for your patient on the dates of service that you provide. So we, again, 70-year-old male referred to OT by the nursing staff due to a recent decline in function. But they don't say what the decline is. Previously resided in the facility. He was modified independent without assisted device within the facility, independent with ADLs. So he's got chronic kidney disease, some hypertension, Let's see. He was referred to OT. Evaluation was completed on 9/10. Excellent rehab potential. And then kind of without skilled OT, this patient's going to decline, blah, blah, blah. But it doesn't really stay in what. So if you've noticed, even this letter of appeal or this summary of this patient really doesn't tell us what his decline in overall function is. We have some information about, lower body dressing, bilateral upper extremity function, where he was, where he got to by the end of the month. We go through, they give us the codes that are going to be used, kind of the definition of the code, what they're going to do, underneath those codes for this patient. And then as you scroll down, the thing that caught me off guard is all of this was written by their CODA. So, again, we don't utilize this information until the end of the review. Then we'll take things into consideration. But if you're going to tell me why it takes you, your skills, your licensure to bring this patient into a skilled intervention such as occupational therapy, you would think that the letter would be written by the actual occupational therapist or the physician. All right, again, so this is just some billing stuff. I'm going to scroll through that quite fast. These are orders. Remember, again, I said orders for outpatient are not required. They're great if you get them. These people do it because they're facility-based, but it's not completely necessary. So they updated once they evaluated, and they're going to do skilled OT 5 times a week for 12 weeks, therapeutic exercises, self-care training, neuromuscular rehab, etc. And again, some updated orders regarding OT. Okay, and now let me turn this. I'm going to skip through actually some of this information because it's just a little order summary, and it just kind of points out to where the orders came through in this patient's stay, which isn't really necessary for us today. Here is their therapy grid. As we talked about earlier, therapy grids are great. We need to know the actual CPT code. We need to know how many minutes were actually provided. We need to make sure that it was provided by someone that is qualified to provide those services. Obviously, I have redacted out any kind of protected health information or any information about the therapist, the CODAs, et cetera. So you can see this is where they put the name and then what their initials would be. So we have the CODA, we have the OT, we have another CODA. So as we go through and look at dailies, we make sure that the correct people are providing those services. Now I have to switch this back. All right. So again, in this overall plan of care, 70-year-old long-term care resident referred by the nursing staff for a recent decline in function. But we don't get a lot of information about what that decline is. Therapy necessary for bilateral upper extremity strengthening, endurance training, ADL training. Without it, we risk further decline, blah, blah, blah. That's all. This is all what we call canned. A lot of therapists just put the same thing on every patient. Without me, they risk further decline. A better way to document would be to say, without this, patient's going to decline in and give what we're working on. But that's okay. It's just part of the overall picture. Plans for this patient is they're going to still live in this nursing facility. So that's one thing, again, to keep in mind. So this is another thing that strikes me as funny is right in here when they start listing prior residence and living arrangements. So this patient was admitted in 2018, and in 2018 they lived alone in an apartment, were independent, la 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 la. That's not really the patient's prior level prior to this illness, injury, whatever, that caused the recent decline in function. So 5 years ago, the patient was living, 5 years before therapy, the patient was living at home. But that's not the prior level for this. So keep that in mind. I mean, you can put that in your history, but really when you start thinking of prior level, we should be documenting where were they right before the reason we're starting therapy now. Now, in this case, there's a few things I want to point out that really aren't necessary. Their initial assessment of the patient, and it's fine to document, but we have things that the patient is independent in and able to complete independently. So obviously those aren't going to be part of our skilled intervention. Initial assessment, great, you assessed those things and noted that they were independent, et cetera. But going forward, when we get to progress reports, probably doesn't need to be there. They did get physician signature on here. And remember, they said 5 times a week for 6 weeks. So they actually put the date range for that 6 weeks that this was valid for, which is great because that lets them know right in the easy to find area, how long they have, unless there is a significant change in functional status that results in a reevaluation, how long they have before they have to recertify. So here is the overall progress report. And this is where I just wanted to note those things that they assessed earlier and the patient was independent in, if you're not going to have those as part of your progress report or as part of the things you're working on, you probably don't need to document those things. You know, we hear a lot, oh, Medicare requires so much of us, so much documentation, and we don't expect you to, you know, write a book, but we expect you to have clear documentation on what you're doing and how you're going to accomplish that. And so repetitively putting things like this that aren't applicable, that you're really not working on, are just wasting your time, and it kind of gums up your documentation. It makes a reviewer have to look through a lot more information. Overall, the documentation on this is good. You know, I am scrolling way down to, I just want to show you an example of their daily notes. This is a good way to utilize both a grid and some subjective/objective information if you wanted to put it in there. So they have a little bit of grid showing here. They have the actual therapy or actual minutes of the therapeutic activity there. And then the CODA in this case has got a place to write a note regarding that patient if something were to happen or if something, you know, came about from that patient that warrants noting. So this is really a preferred way of documenting your daily. It's a very, very nice, easy view, as opposed to just giving a grid where it doesn't give you anywhere to really give any more documentation about that patient. All right, in the interest of time, we're going to move on. One thing I want to show you, this one really quick. This is an 82-year-old female in a skilled nursing facility, Part A resident. So I know it's not outpatient, but fractured humeral head from a fall. She had an additional fall 6 weeks prior that caused a fracture and repair and arm pain. Speech language patient. Okay, so in this case, we did not get any speech language documentation, but I just wanted to show you this in an effort for you to avoid making the same type of mistake. So in here was the Medicare certification for this resident. And at this time, they added speech language services 5 times a week for 6 weeks for a displaced fracture of the upper end of the left humerus with routine healing. And then it says cognitive impairment. So I've never known speech therapy to be provided for a displaced fracture of the upper humerus. If that was the only reasoning and they didn't say anything about cognitive communication, which they really don't give a lot of information, it just would have initially been denied. They say here speech therapy for cognition, okay? And then a few other things when they, again, recertify, again, they're listing the humerus fracture as a reason. And even when we get down here to the orders, speech therapy to treat, again, it's the same thing. They have a little bit more cognitive communication deficits. Treatment will include speech therapy as indicated. So just know that your humerus repair is probably not going to help support medical necessity of speech language services. All right, the next one is another speech language and altered mental status. This person was impaired, they had a UTI, they had some known cognitive deficits as well. So this was actually pretty good charting in this one, and let me scroll up to the top again. The certification is a little bit different because this patient is actually a patient of a skilled nursing facility. So they write out that they need speech for cognition, communication deficits, vocal communication, auditory processing, etc. And so then this one, you know, we learn that this person has altered mental status prior, but then we got a UTI on top of it. And if you know anything about bacterial growth and UTIs in the elderly patients, and she's got a significant colony count, that can also affect cognition. So things that we would expect as a reviewer is that the UTI is being treated and she's got, you know, sepsis, and that they see if the cognition, some of that has straightened out with the treatment of the UTI. So you don't always have to jump into a therapy service. Again, we would hope that most places would treat for the UTI, treat the sepsis, and then see where we are on some of those cognitive and communication deficits. And again, some similar type charting with a daily treatment log. Remember, speech-language pathologists don't have assistants, so if anyone other than the speech-language pathologist does the service, that's a no-go, and we won't pay for it. But they list amount, frequency, and duration. They have the intensity. They're going to do this once a day. They give us the goals for the patient. We have short-term goals. We have a long-term goal. We have, you know, an overall plan for this patient, and it is signed by the physician, so it is certified in the time frames that it needs to be certified. And overall, this was a pretty good, some pretty good documentation on the part of this provider. You know, and again, I'm not going to say if this was a pay or deny, because a lot of that has to do with how long have services been going on, et cetera. All right. So in the interest of time, unfortunately, I had one more claim that, you know, it was neither here nor there in if we needed to go over. I just wanted to make sure I had plenty of examples to show you guys some good and bad documentation. So I'm looking over. I don't see that we have any questions that have come in. So I thank you for those of you who were able to stay on for the additional couple of minutes. We look forward to your further participation in our educational opportunities. And at this time, you may now disconnect.